यतेंद्र, एक बारी ऑडियो चेक कर लीजिए. कैन यू हियर अस? यतेंद्र, आपको आवाज आ रही है मेरी? हेलो यतेंद्र, आवाज आ रही है? यतेंद्र, आवाज आ रही है?
ठीक से तो आवाज आ रही है.
नहीं नहीं, एक बारी ऑडियो चेक कर लो ना.
कैप्चन को तो बोला ना ये अक्षय ने इसको बोला ऑडिबल फिर बोला उसको आइडिया नहीं होगा.
यस, ऑडिबल. आपको आ रही है मेरी आवाज?
मेरे आज तक आ गए होंगे लोग.
कैन यू हियर मी?
कितनी होंगी सर? 10 तो मैं तो उसको बोला 2 तो बोली तुमने. अगर बोले चाय कॉफी पियोगे?
कैन यू हियर मी?
Hello.
हेलो.
Yeah, audible. Yes,
Yeah.
yes.
की भी आवाज आ
यशेंद्र
रही
म्यूट पे
है?
रखो।
आपको बाकी की तीनों स्क्रीन दिख रही है?
अक्षय तुम्हारी वॉइस बहुत लो है।
एम आई ऑडिबल नाउ?
क्या बेटर?
ठीक है। यतेंद्र, मेरी आवाज आ रही है? स्क्रीन दिख रही है चारों आपको?
Yes, visible.
Varanasi here. Varanasi here.
ओके।
Sir, is Varanasi audible?
Okay, all locations, we will go live at 12 o'clock.
Okay.
Okay?
Okay, sir.
12 o'clock, I will start introduction of the company and then we will go live with Dr. Khanna's talk. Okay?
Okay, sure.
Okay. Okay.
शिकायत, कैन यू कॉल मी?
Sure, sure.
Hello, check. Hello, hello, hello. Check. Bardhaman, Varanasi. We will be going live at 12 o'clock. Go live at 12 o'clock. Let me know when we are live. I will start.
हेलो हेलो या प्रतीक ये अक्षय
हाँ जीत.
इट्स ओके सो यू कैन गो लाइव एट 12
Okay. Thank you. Can I have my slides, please? The first slide on the screen. Hello. Slide online. My video is also online. Everybody can see it, right? All locations it is visible, right? Dr. Shobit, can you see the slide?
Yeah, I can see.
Hello. Dr. Shobit, can you see the slides?
Yes. Yes, I can.
Okay. Going live at 12 o'clock, right? मला सांगा क्या चालू करू करू नेक्स्ट स्लाइड करो नेक्स्ट स्लाइड नेक्स्ट Very good afternoon, ladies and gentlemen. Today we have gathered here for a CME which is organized by Integrace. Before we get into the educational topic, I would like to highlight about my organization. Integrace was established in FY 2019. It's a young company. In the successive years, next slide. Yes. So we have grown from 42,000 doctors to 90,000 doctors today. We have impacted lives of around 2.6 lakh patients. Trusted prescription partner choice of around 62,000 doctors pan India. And through our preferred knowledge partner, through our WeConnect initiative, we now cover 1 lakh doctors. We are the leaders in management of peripheral arterial disease with cilostazol. We are also the leaders in management of neuropathic pain and diabetic foot infections. Today, we are gathered here and I welcome all the delegates for the PAD Masterclass. Going forward, I would like to invite Dr. Shobit to take us through the PAD Masterclass and introduce Dr. Khanna. Dr. Shobit, over to you.
Yeah, thank you very much, Akshay. And can you hear me?
Yes, sir.
Is it audible? Right. So
Audible,
thank you very much, Akshay. And first of all, I would like to say a very warm welcome to all the esteemed faculty who has come today in the different locations. In New Delhi, I have Professor Khanna. In Kolhapur, I have Dr. Ranjit Mohite. Then in Varanasi, Dr. Rajiv Khanna. And in Bardwan, far east, we have Dr. Subrata Kundu, who is agreed to be the co-chair with Professor Khanna. So just to brief you about this, the objective or the context why we are doing these virtual as well as physical CMEs, the objective is not only to educate, but also create an awareness that there is so much missed and underdiagnosed with regards to peripheral arterial disease. At times, it would be right to address this as a partially addressed disease, and vis-a-vis the coronary artery disease, which is a completely or a compositely addressed disease. So I would like to introduce Dr. Khanna, and then he will definitely introduce you to the multiple co-writers who are part of these recommendations, who are there from all over India and from various prestigious organizations. So Professor Khanna is the advisor to the Apollo Group of Hospitals in India. He is a senior consultant, interventional cardiologist, and also a vascular specialist for interventions. He is the coordinator for cardiology, cath lab, and vascular services. He has been the past president of Indian College of Cardiology for 2018-2019. He is the chairman of Asia Pacific Vascular Society, President, International Society of Endovascular Specialists, Indian Chapter, past Chairman, National Intervention Council, CSI for 2016-2017. He's a course director for TCT India. He's a member governing council, International Society of Endovascular Specialists, USA, Genome Foundation, Cardiology Society of India, and Indian College of Cardiology. He's in the editorial board of various journals in India as well as abroad, and has worked in the Ashram Medical Foundation, New Orleans in USA, and in Polyclinic des Essais in France. I would request Dr. Khanna now to commence with his presentation and take us.
Am I audible?
Yes, sir.
Okay. Share screen पर नहीं जाना this. Are my slides visible?
Akshay? Yes. Can we see the slides?
Yes, yes.
Okay. So thank you very much, Integrates, Dr. Seth, and all of you for joining today's, master class on Indian consensus statement for the management of lower limb extremity disease. It is indeed honor to have 3 cities connected with Dr. Ranjit Mohite from Kolhapur, Dr. Rajiv Khanna from Varanasi, and Dr. Subrata Kundu from Bardwan, who would be individually, taking lectures after my talk and question and answer to just spread this message of understanding the Indian consensus statement for peripheral vascular disease. Now, let me just take you through the brief and the history of the consensus statement. This is the only consensus statement or guidelines for the management of lower extremity peripheral arterial disease in our country. And there was a long met need that we didn't have any consensus. We didn't know how the disease pattern in India and how to go about and have an authentic algorithm to treat lower limb extremity disease. And because of this need, the top experts from the country sort of got together with the help of Integrates, who are sort of passionately attached and associated with the the treatment of peripheral arterial disease in the country. So this was in 2022, when we got together, and the panel included, or the directors included myself, Dr. Vinay Krishnan, who is the Director Professor of Cardiology at LPS Institute of Cardiology at Kanpur, which is the flagship institute for cardiology and cardiovascular disease in Uttar Pradesh, and this is the third biggest center in the country, where they are doing about almost like 100 cases a day in interventional cases a day in and about 8 to 10 open heart surgeries a day, with 12 DM cardiology seats and 8 MCH cardiac surgery seats. We also had Dr. C.N. Manjunath, who is now a member of parliament, but then was director professor of the famous Jayadeva Institute of Cardiology, which is the biggest cardiovascular training program in the country in Bangalore. We had Dr. Sanjay Tyagi, who is a director professor of cardiology at GB Pant Hospital. Dr. Rawal Jindal, who is a vascular surgeon in Mohali, Chandigarh. Dr. Manoj Chadda, who is an endocrinologist in Mumbai. Dr. Natesh, who is a professor of cardiology at Jayadeva Institute of Cardiology. Dr. Girish Varawadekar, who is a very famous interventional radiologist in Mumbai. Dr. S.K. Wangnu, who is a very famous endocrinologist and specializes in diabetic foods. Dr. H.K. Chopra, the ex-president of Cardiological Society of India. Dr. Priya Jagia, who is the professor and head of radiology at All India Institute of Medical Sciences, New Delhi. Dr. Rajiv Bagarata, who was the director and principal of SMS Medical College, Jaipur, and also a very good interventional cardiologist. Dr. APS Suri, a podiatrist from New Delhi. Dr. Sokan, who is the vice president of Cardiological Society of India from Kozhikode. Dr. Rajesh Vijayvargiya, who is the professor of cardiology at PGI Chandigarh. Dr. Raman Puri, who is the president of the Lipid Association of India. Dr. P.C. Gupta, who was the president of the Vascular Society of India. Dr. Vimal Mehta, who is a professor of cardiology and research at GB Pant Hospital, New Delhi. And Dr. Jagdish Suri, who heads EtheroPoint in US and is mainly involved in AI in peripheral vascular disease. So with this panel, we had a lot of discussions, and many manuscripts were actually made and then revised after brainstorming and collecting a lot of literature. And finally, after many months of brainstorming and writing and rewriting and correcting the manuscripts, this was finally published in the Journal of Indian College of Cardiology, and this has the maximum site scores for this topic. If you Google, you will find it at #1 position. And this was then officially launched at the Asia Pacific Vascular Interventional course, which is our flagship meeting for the APFIC course at New Delhi 2 years back. So with this background, I'll just take you briefly for the next 35-40 minutes on the context setting, PAD overview, which is peripheral arterial disease overview, diagnosis of PAD, which is peripheral arterial disease. It is also known as lead, lower limb arterial disease, pharmacological management of this, diabetic foot, and treatment of peripheral arterial disease, and some key takeaway messages, after which the co-panel from individual centers would be talking about the next topic. Now, let me come to the context setting. PAD is one of the most under-recognized and under-treated atherosclerotic vascular disease in India. It is often overlooked because of lack of population or physician awareness. In the Indian context, not only conventional atherosclerotic cardiovascular disease risk factors are the risk factors for peripheral arterial disease, but there are also unique non-atherosclerotic risk factors which contribute to peripheral arterial disease in India. most patients may not reach the level of specialist, and when they do so, it's all, many a times too late, and the disease is fairly, progressed, and these patients land up with us in a state of critical limb ischemia or in a state of, uh, you know, in a state where they actually have nothing to be offered except an amputation. At present, majority of PAD in our country is still managed effectively by specialists, and primary care physicians who deal with majority of PAD population need to be upgraded in terms of diagnosis and management of PAD in early stages of the disease. And that is the thrust of this talk, that how physicians and at their clinics can actually pick up this disease early in their natural history, and actually prevent many patients from losing their leg or losing their life. And because there were no guidelines and consensus which was available in the country, there was a very strong need for this consensus to be made and be published. And it was finally published in the Journal of Indian College of Cardiology in 2023. Now, let me give you a little bit idea about the global prevalence of peripheral arterial disease. The global prevalence is about 5.6%. The prevalence is higher in high socioeconomic countries or high income group countries, and lower in low economic income countries. But in India, the prevalence is about ranges from 7.6 to 26%. And this variation is because there were no studies available in the country up till now. And Integrace, with the help of Asia Pacific Vascular Society, is on a mission now to have many PAD clinics across the country and collect this data by home or clinic ABI monitoring, and actually have the data of prevalence of peripheral arterial disease in the country. Now let's talk about the risk factors. There are some conventional risk factors which are common to atherosclerotic disease anywhere in the body, which could be coronary artery disease or cerebrovascular disease. These conventional risk factors are smoking, diabetes, hypertension, dyslipidemia. These are the common ones, and hyperfibrinogenemia. But apart from this, the unique risk factors for peripheral arterial disease are age. Age is one of the most important risk factors, and as the patient ages, the incidence and prevalence of peripheral arterial disease actually increases. Apart from age, obesity, which is a very common problem now in India, is also a risk factor. And maybe addressing obesity by lifestyle changes, diet, or drugs may actually reduce the incidence of peripheral arterial disease. Apart from this, we also have alcohol intake, renal impairment, and hyperfibrinogenemia as one of the unique factors or risk factors for peripheral arterial disease. What is very unique here is if you have more than one risk factors, it is the risk actually is not additive, but it is compounding. So if you have two risk factors, you have at least 4 times risk. If you have 3 risk factors, the risk actually becomes almost 16 times. And if you have 4 risk factors, your risk actually goes up to 64 times. Now, if you look at the clinical manifestation of peripheral arterial disease or the lower limb arterial disease, this can be sort of classified into 4 stages. It could be asymptomatic, which is a very common stage. It could be patient could be coming with intermittent claudication, or the patient may have fairly advanced disease and come with critical limb ischemia or acute limb ischemia. Now, if you look at it, asymptomatic peripheral arterial disease is actually represents 50% of total population of patients with peripheral arterial disease. The atherosclerotic disease is present, but these patients do not exhibit any symptoms because of 2 reasons. One, they may be diabetic, or the other ones could be they are mostly sedentary, or they have arthritis because of old age, and they are not walking enough for the symptoms to appear. Now, 70% of asymptomatic PAD may remain undiagnosed because of this fact, and it is seen that these patients have reduced functional performance and reduced quality of life. And nearly 35% of cases with undiagnosed asymptomatic PAD can develop new occlusive lesion within a year. So, not that these patients who do not have symptoms are okay, but these are the patients who can actually get into a lot of problems. And within a year, almost one third of them would probably get into a stage where they present with critical limb ischemia or intermittent claudication. And in spite of the fact that these patients do not have symptoms, if they have peripheral arterial disease, there is a significant increase of risk of all-cause mortality and cardiovascular events necessitating early diagnosis and treatment to prevent these sort of complications. So, in nutshell, early detection is crucial in preventing complications such as intermittent claudication, rest discomfort or rest pain, ischemia, gangrene, and in worst cases, the danger of amputation or danger of losing life. Now, with this sort of context setting, it becomes very clear that this disease is underdiagnosed in the country. This is usually neglected in the country, and but the incidence and prevalence is quite high. And there are four stages of this disease, and many of times you have asymptomatic patients, but the disease is disease is pretty common in these patients, and this definitely leads to a higher incidence of mortality and cardiovascular deaths in these patients. So, any patient who is not symptomatic but has risk factors for peripheral arterial disease should be screened. The second group of manifestation is intermittent claudication. In intermittent claudication, what happens, it is equivalent or synonymous or maybe similar to stable angina in coronary artery disease. Here, the patient walks for a certain distance and has discomfort or pain in the leg, and he has to stop, and then he stops, and then he can walk again. This is similar to stable angina, where what happens is patient, can walk to a distance, then they have angina, and then they sit and then walk again, and they have relief of chest pain because of opening of collaterals, and this we call as walk through angina. So this is a disease which is just says that there are blocks, but these blocks, can allow the patient to work or walk for some time, but after that there is a ischemia because the oxygen demand increases or the blood supply demand increases, and because of relative ischemia there is a leg discomfort. So this is the second stage, which probably can also be managed with good medical therapy. And after this, the patient slips very rapidly into critical blocks, which can lead to ulcer formation, non-healing of the ulcer, and also sometimes, gangrene of the foot. Or sometimes what can happen is acute limb ischemia, where the patient did not have any disease, but because of a clot formation or embolization from heart or from aorta, these patients can suddenly go into a stage of whole limb and gangrene, and these patients have to be treated like an acute emergency. So if you have to draw a parallel to coronary artery disease, asymptomatic patients is like asymptomatic coronary artery disease. Patient with intermittent claudications are akin to patient with stable angina. Patients with critical limb ischemia are akin with unstable angina or acute coronary syndromes. And acute limb ischemia is like acute myocardial infarction in coronary artery disease. So, with this background, let's see the second part of this talk, how to diagnose this disease. While we are diagnosing this disease, it is very important. It is very important that we go through the same steps as in coronary artery disease. We take a good history, and this history basically looks at the personal and family history of coronary artery disease, cerebrovascular disease, and peripheral arterial disease. We take the history and look for risk factors, which could be conventional risk factors or risk factors which are specific, as I told you, for peripheral arterial disease. We look for comorbidities and cerebrovascular disease, renal disease. And then we look for symptoms related to different vascular territories. We look for lifestyle habits, sedentary habits, dietary patterns, physical activities, and get some tests done for conventional and unconventional risk factors, and then see the patient physically. So apart from this, the physical examination, which is the most important, is basically if you do two physical examination in your clinic, that is going to pick up almost 90% of patients with early or non-manifest peripheral arterial disease. So what we look at is we just palpate pulses in both the carotids, in both the radials and brachials and ulnars. We palpate pulses in the femorals, and we palpate pulses in the popliteal artery and pulses in the posterior tibial and dorsalis pedis arteries. If all the four limb pulses are palpable and have good volume, then you can almost be sure that this patient does not have a serious or high grade peripheral arterial disease. The second test which we do is an ankle brachial index. What we do is we take a pressure in the calf, blood pressure in the calf, which is similar to how you take blood pressure in any individual, and you also take a blood pressure in the ankle, and then you divide the ankle pressure to the brachial pressure and get to index which is known as ankle brachial index. And I'll be talking about it, how to interpret this ankle brachial index. So one knows how to take a blood pressure in the arm. This is how you take a blood pressure in the foot or ankle, and then either you can palpate the arterial pulsation here, or you can use a handheld Doppler, or you can use a stethoscope. We are actually in a process where we are comparing handheld Doppler with the blood pressure instrument and using stethoscope, and validating that form of ABI measurement, and then if that turns out to be it's validated, then what we are going to do is validate this technique and be sure that using stethoscope you have similar sensitivity and specificity of reading of ABIs, and then it can be widely used across the country. All this was actually published in the Journal of Indian College of Cardiology, and in our consensus statement. You can have a copy of that either online or physical copy, which must be available there. It's been freely supplied by Integrace, and can go through it. It's at least a 30-40 pages document, which is very, very informative. Now, I have told you about the ABI. If you do these two tests and see that there is no ulceration, or the temperature is not low, and there is no gangrene, and there is no the foot movements are fine, you can actually diagnose peripheral arterial disease with very high level of accuracy. Why ABI is very important? First, for not only for diagnosing peripheral arterial disease, but in the lower limb, but also for knowing the extent of the disease or severity of the disease. It becomes a very important tool or method to actually monitor the success of revascularization in these patients. It also is very important in reducing the risk of amputation, and it becomes important in treating patients of critical limb ischemia, like patients with leg ulcer and impending gangrene and non-healing wounds. And it directly predicts future cardiovascular related morbidity and mortality, because it is giving you the severity of the disease. The disease is same in lower limbs and in coronaries and in aorta and brain circulation. So if you have a severe peripheral arterial disease in the lower limb, it actually is a window which tells you to peep into different circulatory territories and look for cardiac disease, coronary artery disease, and cerebrovascular disease in these patients. And patients who have peripheral arterial disease, 90% of these would have either coronary artery disease or cerebrovascular disease or both. Now, what is the confirmatory test to diagnose the peripheral arterial disease? So, if you have absent pulses or feeble pulses, or if you have a deranged ankle brachial index, in that sort of a situation, what we do is we send the patients for a duplex scanning. Now, just coming on to the values, any value between 1 to or maybe zero point 0.9 to 1.4 is an acceptable value, and it sort of gives you an idea that there is no significant peripheral arterial disease problem. If the value is more than 1.5, 1.4, it actually signifies that these vessels are calcified and they are non-compressible. That means the patient has arteriosclerosis, and this should be referred to a specialist. If the value is 0.8 to zero point 0.9, it is a mild form of a disease and it can be managed medically. Many of these patients are claudicants, and these patients can be treated medically. Now, if you have a moderate disease or you will have an ABI from zero point 0.5 to zero point 0.8, and any ABI less than 0.5 signifies very severe form of arterial disease, and any ABI less than 0.8 should be referred to a peripheral specialist or endovascular specialist like cardiologists who deal with peripheral arterial disease, or sometimes vascular surgeons or interventional radiologists. So I've already sort of talked about this. Now, if you have abnormal ABIs and pulses, then you send these patients for duplex scanning, which is similar to an echocardiography, where you can actually see blocks in these arteries. You can see the level of blocks, the degree of blocks, and also the flow through Doppler studies. This can give you a fairly good idea of what the problem is, the number of places you have plaques, and the degree of stenosis. It is very sensitive, and the sensitivity and specificity is around 80 to 97%. And this should be done in all patients who are actually, having peripheral arterial disease. Now, once your Doppler shows a problem, then these patients are referred for higher centers for revascularization. And if the revascularization is contemplated, if the renal functions are normal, the best way to do an angiography is to do a CT angiogram. And if the renal functions are abnormal, what we can do is an MR angiography where renal functions look okay. Now, let me then, if you have a patient, whose angiogram, either a CT or an MR, shows multiple levels of block or a significant block, then you take these patients for revascularization, and the revascularization can be done either by surgery. But nowadays, if you have good interventional cardiologists who actually knows how to do vascular interventions or have been trained to do this, which is the aim of our knowledge spread program, and also our two teaching courses, one of which is Asia Pacific Vascular Intervention course, which is the biggest course for teaching vascular intervention and vascular diseases in the whole of Southeast Asia. Or we have a dedicated interventional course, which is known as the ICE International Course of Excellence, which we have been running for the last 16 years. Then this can be treated by interventional cardiologists, and some surgeons or radiologists who are trained in the vascular lower limb work can also be doing this. Now, patients who do not respond to medical therapy or who have critical disease should go for endovascular for revascularization, and it is always advisable to do endovascular revascularization as compared to surgery, because surgery has always been shown to have higher morbidity and higher mortality. Now, this is the sort of a, algorithm when to send patients for, intervention or revascularization. Now, these are the patients who have either a critical limb ischemia or an acute limb ischemia, and or patients of intermittent claudications who have where the claudication distance is less than 100 meter, and or patient has rest pains, and these are the patients who are likely to get into major problems. They should be referred for interventions or surgery. Now, coming on to the pharmacological treatment, which is very important for all of us, which is actually the baseline for the treatment. This is very important and should be, clearly understood by all the treating physicians. Now, once we are looking at, just 1 second. Okay. Now, once we are looking at, the medical therapy, the first part is control of risk factors. As I told you, I'm not going to be discussing in detail. All of us are, and all of you are great physicians, and we are dealing with these risk factors for coronary artery disease or for diabetes, and it is same. I'll just give you some take-home messages about it. Then the second part of the therapy is antiplatelet or antithrombotic therapy, which is also the mainstay, and a special mention about silestazole. So once we are talking about glycemic control, the patient's diabetes has to be well controlled, the pressures have to be well controlled, cholesterol has to be well controlled, and obesity, which is a very unique and specific risk factors for peripheral vascular disease, has to be controlled pretty well. In glycemic control, what is very important is these patients' HbA1c has to be less than 7 in most of these patients. If you're looking at dyslipidemia, the LDL goal should be less than 50 if you have a pre-existing atherosclerotic cardiovascular disease, and the patient is in a very high risk category. And if the patient has established coronary artery disease or multiple atherosclerotic disease at multiple points, then the LDL goal has to be less than 30. One should always get a lipoprotein little a level, and a level of less than 50 milligram per deciliter is advisable. So this is the consensus statement, which is there in the statement provided to you, and this should be followed in all patients. So obesity, again, now we have good drugs to control obesity, and especially drugs like, Monjaro or GLP receptor 1 receptor antagonist. These are the drugs which are advisable in these patients, especially if they are diabetic and obese, to control peripheral vascular disease. Now, coming on to the antiplatelet and antithrombotic, therapy, it has been shown that at least one antiplatelet has to be given. If the patient goes for revascularization, dual antiplatelet can be given. Of all the antiplatelets, which are available, aspirin, clopidogrel, ticagrelor, prasugrel, and silestazole. Silestazole has class 1 indication for treating peripheral arterial disease. There's also a new concept now, because every patient of critical limb ischemia or patient of peripheral arterial disease actually has both thrombotic component and, you have a platelet-rich a plug which is ruptured, and there is a platelet plugging or clogging at that position, which leads to thrombosis. So what we need to do is to target both the platelet aggregation and platelet adhesion, and also target the clot which is being formed there. So this is same in coronary artery disease and same in peripheral arterial disease. The knowledge came to us after a very large trial, which was the COMPASS trial. It had two components, the COMPASS coronary CAD component and the COMPASS PAD arm. Both revealed that your major adverse cardiovascular events or major adverse limb events, total vascular amputations, and interventions for peripheral arterial disease were reduced at in a period of 12 months if the patient had low aspirin and a low dose rivaroxaban, which we now call this therapy as a dual pathway inhibition. So we have moved from single antiplatelet therapy to dual antiplatelet therapy and dual pathway inhibition. And this has been a very, very important discovery. And if you are treating intermittent claudication, the drug antiplatelet of choice is silestazole. But if you are treating patients after surgery or after intervention, then we need to give dual antiplatelet agents. And if the patient has become stable after a time, we need to change dual antiplatelet to single antiplatelet plus low dose rivaroxaban or dual pathway inhibition. Now, silestazole, as I told you, is a very unique, uh, you know, very unique antiplatelet agent. It is a phosphodiesterase 3 inhibitor. It leads to, vasodilatation. It has antiplatelet activity, antiproliferative activity, and because of these three, it is specially recommended, has class 1A indication both by American College of Cardiology and European Society of Cardiology guidelines. It improves walking distance, it improves the lower limb functional capacity and quality of life. And various guidelines today do not recommend pentoxifylline in the management of PAD. Now, coming on to diabetic foot and peripheral arterial disease in diabetes. So this would be one of my last part of the presentation. You do have 4 times increase of risk of developing peripheral arterial disease in patients with diabetes. And this can lead to permanent disability, functional disturbance, and poor quality of life. Sometimes diabetic foot can lead to an ulcer formation, and diabetic foot ulcers are known as DFUs, and they are very difficult to treat. Now let's come to the statistics. 50% patients of diabetes have peripheral arterial disease, which can present as discoloration, ulcer formation, coldness of the limb, deformity of the limb, and sometimes even gangrene. So what happens, and then once you have these ulcer formations, these are very difficult to heal because of many factors which I'll be discussing, and often leads to an amputation. If you look at the pattern of disease in diabetic foot, about 1/3 of the disease is in the femoropopliteal segment, and about 1/3 of the disease is in the below knee segment, and 1/3 is in the femoral and inguinal vessels. Now, if you have a patient of long-standing diabetes and if the ABIs are poor, now these patients should, and if the creatinine is fine or the eGFR is fine, these patients should undergo duplex scanning followed by a CT angio. If it is abnormal, this patient should have an MRI angio. All of these patients should have an ABI measurement, and if the ABI is too low, then these patients have very high risk of ulcer formation or gangrene formation, and these patients should be referred to, especially to doctors like us, where we are specialized in vascular treatment apart from coronary treatment in our patients. Now, patients of diabetes with more than 45 years of the age should have an ABI and then should be followed every 5 years. And if you have, if you do not have an ABI, or if you have a patient who has sort of, undergone treatment, TBI, which is toe pressure index, is also what we sometimes measure. Anyway, 2% of patients are very common in diabetes. Amputations, even if you do amputation, they don't heal very well. And the relapse rates in diabetic foot ulcers are almost 30 to 40%. Usko bula lo internet. Now, once you have a patient of diabetes with a diabetic foot, it is very important to identify the foot at risk This can be done by inspection of the foot, and where what we do here we look for ulcer formation or break in the skin. We look for foot deformity, and we look for the temperature change as well as sensory and diabetic sensory component of diabetic neuropathy, where you have a loss of sensation or loss of proprioception. The patient's family has to be educated that these patients should keep their foots dry and clean and should not get injuries, and they should have proper footwear. And if you have a diabetic foot ulcer, it should be treated with a lot of care and as a priority. So I have given you a lot of points which I'm not going to be discussing because diabetic foot is a separate point in itself. I'll be sort of giving you now just the key home or takeaway messages now, which are given in our consensus statement. Given the substantial burden of PAD risk factors in India, PAD screening is advisable in diabetics and adults above the age of 50 years with one or more risk factors other than diabetes. Second, initially, the basic and conservative approach of ABI is considered as the first line of non-invasive diagnostic approach, irrespective of symptoms and other associated risk factors in all regular PAD patients. TBI is advisable for PAD diagnosis if ABI is more than 1.4. That means if the arteries are very hardened or they have arteriosclerosis, then you go to the TBI, which is a toe brachial index, where the arteries are not calcified. Duplex ultrasound is a useful non-invasive diagnostic modality for PAD. When available, it should be preferred to ABI for diagnosis and characterization of the disease. CTA is helpful in patients to do an angiography where ABIs are deranged and duplex shows some abnormalities. And this should be done only if your renal functions are fine. Contrast enhanced MRA can be done in these patients where the renal functions are poor. And invasive angiography should only be done when we are thinking of revascularization. Intensive glycemic control in our diabetic patients is important, keeping the HbA1c less than 7. BP target has to be less than 140 by 90 or 85. LDL goals have to be less than 50, and patients who have severe form of coronary artery disease and cerebral vascular disease, here the LDL goal has to be less than 30. Ideal body weight maintenance is important as it's a very important risk factors. We can take help of weight reducing medications if required. Single antiplatelet drugs can be used, but if you have to choose an antiplatelet drug, the drug of choice for intermittent claudication and peripheral arterial disease is sildenafil, and especially so because it has an anti-proliferative effect, it has a vasodilatory effect, apart from very potent antiplatelet effect. Then the prevalence of diabetes in PAD patients and PAD in diabetic patients is pretty high, and complete screening should be done in these patients. In India, despite all significant prevalence despite a significant prevalence of diabetes, practice of foot hygiene and foot care is very poor, and this should be encouraged or taught to all the patients who have diabetes and come to the clinic of primary care physicians or diabetologist or physician. Self-foot examination is very essential for early diagnosis of diabetic foot and should be taught to the patients by the physician. And if the patient develops a diabetic foot ulcer, then it is very important to involve multiple specialities and which includes a good interventional cardiologist, a diabetes expert, and good podiatrist. The data for amputation is lacking in India, but it can be many a times it can be reduced if the patients are followed properly. They are referred in time, and the patients treatments is started quite early in the natural history of the disease. So I'll end here, and we'll take some questions. And before actually dispersing, and for the second talk in each centers, which are in Bardhaman, in Varanasi, and other places. What I would do is I would, on the behalf of Asia Pacific Vascular Society, which is the biggest society for vascular, teaching and vascular research in the Asia Pacific region, we would invite you for our 17th edition of APVIC course, which is going to be held from 11th to 13th July in 2025. This is the biggest vascular conference in the Asia Pacific region, and we have the top experts from all over the world to be attending this conference and delivering lectures in this conference. And we also have Nobel laureates attending this conference. So all of you are invited. We'll make registration free on the request of Integrace. And the course is in New Delhi from 11th to 13th next month, which is in July at Hotel Oberoi. We also take this opportunity because we have one of the centers in Varanasi to block your dates for the annual conference for the Indian College of Cardiology, which will be held at Taj Ganges from 19 to 21st September 2025. And we will be very happy to host you there in Varanasi, along with Dr. Rajiv Khanna and many others. And we will definitely have a very good cardiology conference. All of you are invited to join this course as well. Thank you very much.
So thank you very much, sir. So we will be taking questions in the alphabetical order. That is, we start with Bardhaman, then we move on to Kolhapur, and then Varanasi. So we'll be taking 3 questions from each location. Yes, Mr. Tikayat.
Yes, sir. We have a question from Bardhaman. Handing
Yes,
over to
please.
the doctor.
Yes.
Thank you, Dr. Khanna, for giving us such a valuable insight in a peripheral arterial disease. But I just want to highlight that in case of limb pain, in whether it is in the lower limb or upper limb, there are 2 components. One is the vascular and one is the neurogenic. Because when the arterial supply is destroyed or diminished, the artery, which is called vasa nervorum, which supplies the neurons in the, long fibers in the peripheral limbs, that is also jeopardized. So there are 2 components is always there. One is the atherosclerotic and one is the neurogenic. Atherosclerotic part can be modified or can be treated with this vascular surgery. But what about neuropathic pain? It usually persists even after the vascularization. So any advice or any thought about this?
Okay, so especially in diabetics, there are like 3 things happen. One is the diabetic neuropathy, which actually could be 2 types. It could be sensory, it could be proprioceptive. So what happens because of this, the patient has develops a joint deformity, the patient develops paresthesia or anesthesia, and there is a more pressure on the skin, and it actually breaks down and forms an ulcer. And then these ulcers get infected because of the poor supply and diabetes. The infection is usually difficult to treat. And because of the poor blood supply, the ulcer starts, the demand of oxygen is increased within infective foot, and the ulcer starts becoming bigger and bigger. And then what happens is, it converts to a non-healing or a bone deep ulcer, and the patient often requires revascularization and good podiatric care. So this is one component. So whenever we are treating a diabetic foot, it has to be a multi-speciality role there. You should have the endocrinologist treating it. You should have sometimes a podiatrist or a neurologist treating this. for maybe some drugs may help in terms of neuropathic pain, but it is difficult, if you have proprioceptive involvement in a diabetic patient to actually control it. And then what happens is what we do after the ulcer healing is we give them a special test called a foot pressure testing, and they give them special insoles where the points where the pressure was occurring, it is offloaded by a special footwear, and those areas are prevented from re-breaking. Sometimes the pain is really bad, it doesn't respond to drugs, and then in those sort of situations, we sometimes often give nerve blocks to these patients.
So I have a question. Sir, in measurement of ABI, you need an ultrasonic hand probe. Is it adequate to measure with a stethoscope in practical this thing?
Yes, so that is what I told you. We can measure the systolic pressure with palpation alone, along with the blood pressure curve. We can do it with an stethoscope as we do it in the brachium, in the arm, upper limb, or we can use a handheld Doppler. I think by the stethoscope, it can be easily done, but this is what we are, evaluating in this trial. No, there is no validation study which actually compares handheld Doppler versus stethoscope or auscultatory method for measuring ABI. If we actually are able to successfully validate, then this becomes the standard of care and it's very easily available. But, I don't, in my practice, I always use a stethoscope, and it works out in most cases where the ABIs, where the pulses are palpable. In some sort of a situation when the pulses are not palpable, then it doesn't work out, then the handheld Doppler is the only way to know ABIs. Or maybe a duplex scan is the only way to correctly determine the ABI.
Second question, sir. You have described PAD as CAD equivalent,
Right.
but nowhere in CAD management, silostazole is used. Why?
No. Yeah, that's why I told you there are two things. One, it is a vasodilator, and which is very specific for lower limbs, apart from being a good antiplatelet agent. None of the trials which have been done on coronary arteries, the aspirin was the only drug which was first tried for non-interventional patients of coronary artery disease. Since then, no trial has got the courage to actually take aspirin off and try a new drug for these patients. Subsequently, when interventional techniques and stenting angioplasty came in, all the trials, it was seen that adding second antiplatelet agent to aspirin actually worked out better in terms of preventing stent thrombosis and stabilizing the plaque. Different drugs were tried, and of these drugs, there were direct-acting drugs like prasugrel and ticagrelor, or pro-drugs like clopidogrel. But silistazole was never tried in coronary artery disease in any of the trials. So it may work, it may not work, but we are not sure. But none of the trials, none of the guidelines give silistazole and even a class 2 indication for being used in patients of coronary artery disease. In our practice, what we do, if you have a patient of peripheral arterial disease and coronary artery disease, we initially give them dual antiplatelet, and dual antiplatelet is usually in our practice is aspirin or ticagrelor or aspirin plus clopidogrel. And after about 6 months, we reduce this to single antiplatelet agent from this group, and we add silistazole if the patient also has a claudication or has undergone intervention in the lower. But for claudicants alone, this has a class 1 indication by ACC as well as AHA. That is where this drug has been tried and has got a class 1 indication. And probably it is because of the vasodilatory effect, apart from being a good antiplatelet agent.
So here we have been discussing about the atherosclerotic vascular disease, but there are some non-atherosclerotic vascular diseases which can present?
Yes. So, in this, because of the paucity of the time, I did not discuss those. They're all there in the, consensus statement. We have three very unique diseases in India, which are non-atherosclerotic. One is Takayasu arthritis. The second one is Burgess disease, which is thromboangiitis obliterans. And the third one is autoimmune vasculitis of the lower limb. So these three, diseases are quite common in India, and they are treated in a different way. But because of the paucity of the time, although they are there in our consensus statement, which you all have right now or may be having, those are very specific diseases and they are managed in a very different way.
Thank you, sir.
So can we move to Kolhapur? We can come back to Bardwan later.
Sir, any questions?
Are there any questions in Kolhapur, or shall we go to
We
directly
can-
to Varanasi?
We can move to Varanasi, sir. Thank you.
Right.
Thank you very much, Dr. Khanna, for a wonderful deliberation. I'm Rajiv, who is going to give the next lecture over here. Something which we don't have too much of experience is, does silostazole has any role after the intervention to prevent restenosis? Because there has been some, the second thing is it has some value in bringing down the HDL. It has a very positive lipid profile also, which is coming up as some data. So is there any role of prevention of the after the intervention is done? The role of silostazole?
Yes. If you talk about the guidelines would have a class 1A indication for claudicants, peripheral arterial disease and claudication. For patients who undergo revascularization, which is for very short distance claudicants, or which is there for a more advanced disease like critical limb ischemia, these or an impending gangrene or ALI, these patients undergo interventions, and post-intervention, there are no major trials which give it class 1A indication in these patients. But when we have to choose a dual antiplatelet agent, which we normally choose, we actually, in my practice and most of the vascular people in the world, would prefer to use this along with any other antiplatelet agent, could be aspirin or could be clopidogrel in these patients. But after the COMPASS trial, we have been little more wiser to understand that there are actually two components which happen, especially in a patient who has undergone intervention. That means the disease was almost up to the stage of CLI, where it is prudent to add a low dose rivaroxaban, which addresses the thrombotic path, and a single antiplatelet agent. Although the COMPASS trial actually used aspirin, any of these antiplatelet agents can be used. And many of us actually use clopidogrel if it is only confined to a lower limb, clopidogrel and low dose rivaroxaban. If it is for stable coronary artery disease, we use aspirin and low dose rivaroxaban.
The second question is, sir, if we use silostazole, does tachycardia or headache becomes a very nagging problem? How much have you faced, and does it necessitates to stop the medicine?
No, almost never. I use it very often, almost never. But one thing, because of the paucity of time, I skipped many of those slides. The most important contraindication, especially in cardiac problems for silostazole, is heart failure. If you have heart failure, silostazole is totally contraindicated. And of course, it is contraindicated if you have hypersensitivity or pregnancy. But apart from these two, heart failure is something one has to be very sure. It should never be given in a patient of heart failure.
Thank you, sir.
So there is one question online, and this is a doctor who from Patna, and the question is: when do I send the patient for intervention with a diabetic foot infection, or till what stage should I treat him myself?
Yeah,
So
so
he
that
has
is what.
mentioned about the staging of the ulcer, but he has clearly said that it is an ulcer.
So
So we
exactly this is what the guidelines mention and what I touched upon. If you have a patient of diabetic foot ulcer, it has already crossed the stage of claudican. It is the ABIs there would be less than 0.7, 0.8, and these patients would have a multiple level of disease. In that of sort of a situation, the patient should be referred to a vascular clinic or a vascular specialist where there is a good setup where there are endocrinologists to take care of diabetes, where there is a good diabetic foot center. That means you have a way to treat and diagnose neuropathy. You have a way and to treat and the pressure points and offload these. You have a good podiatrist who can take care of the infection, and you have a good interventional guy or a surgical guy who can revascularize this limb and then do surgery to debride the necrotic tissue, and if required to do a minimal amputation and put a flap. So it's a multi-speciality issue and a setup which is required. And these patients, if you have a diabetic foot ulcer, it is better not to manage at the clinic level. The disease is fairly advanced, should be managed by a good vascular clinic or a diabetic foot center.
Fine, thank you. So I believe now one more question has come, that is 2D echocardiography for lower extremity essentially mandatory before starting silistazole?
No, it is actually not. But, for claudicants, actually not. But it is better, if, as I told you, if your pulses are weak or absent, if your ABI is less than 0.9, 0.8, in those sort of situations, it is prudent to do a duplex ultrasound of the lower limb. It has two components: a 2D scanning of the, you have a scan of the arteries of the lower limb where you can see the plaques, you can see the calcification or the thrombus. And second, you have a Doppler study, which actually looks at velocity, acceleration, which actually gives you the hemodynamic significance of that block or the degree of stenosis. So these two are very important. And I would say if you have, but it should not be
So the embolism, and there are some vascularities like uh, peripheral vessel disease. Now, what the important is, peripheral arterial disease screening is compulsory in all diabetics and above 50. And how will you screen? Just by palpating the peripheral pulses. जसं आपण नेहमी रेडियल आर्टरी पाल्पेट करतो तसं सेम ईच अँड एव्हरी पेशंटचा एक हॅबिटच बनवायला पाहिजे की एल्डरली पेशंट्स आहेत अबव 40 आहे, palpate the dorsalis pedis. What is the location of dorsal pedis? Just lateral to the tendon of the external hallucis longus. Just lateral to the external hallucis longus tendon, where we palpate dorsalis pedis artery. Second thing is posterior tibial artery, where we palpate just between the medial malleolus and the heel, midway between the medial malleolus and the heel. These two arteries we should palpate in each and every patient. Each and every कंपल्सरी अबव 40 जसं आपण रेडियल आर्टरी पाल्पेट करतो तसं कंपल्सरी डॉर्सलिस पिडीसवरती हात ठेवायला पाहिजे. आणि डॉर्सलिस पिडीस जर ॲबसेंट लागली तर पोस्टियर टिबियल बघायची. कारण की ऑलमोस्ट 10% नॉर्मल पॉप्युलेशनमध्ये सुद्धा डॉर्सलिस पिडीस ॲबसेंट असू शकते. इफ डॉर्सलिस पिडीस ॲबसेंट, लुक फॉर द पोस्टियर टिबियल. पोस्टियर टिबियल इज पाल्पेबल, फाईन. त्याच्या एक स्टेप पुढे जाऊन काय करायचं आहे, अँकल ब्रेकियल प्रेशर इंडेक्स. व्हॉट इज अँकल ब्रेकियल प्रेशर इंडेक्स? त्यांनी एक छान डायग्राम दाखवली होती. बीपी कप जसं आपण हातात बघतो, ब्रेकियल आर्टरीला बीपी कप लावायचा. आपण नेहमी सिस्टॉलिक डायस्टॉलिक बीपी तसं बघतो, तसं सिस्टॉलिक बीपी किती आहे? सिस्टॉलिक बीपी 130. सेम लोअर लिम्बला काफला बीपी कप लावायचा. एक तर डॉर्सलिस पिडीस पाल्पेट करा किंवा पोस्टियर टिबियल पाल्पेट करा पाल्पेटरी मेथडनं. सेम ऑस्कलेटरी मेथडनं पोस्टियर टिबियल आर्टरी ऑस्कलेट करायची. ह्याचं सिस्टॉलिक ब्लड प्रेशर जे आहे अँकलचं आणि ब्रेकियलचं, ह्याचा रेशो काढायचा. नॉर्मली रेशो किती असतो? 1च्या वरती. जर तो 1च्या खाली असेल तर सस्पेक्ट दॅट दिस पेशंट इज हॅव्हिंग पेरिफेरल आर्टेरियल डिसीज. 0.9च्या खाली असेल तर ठीक आहे. जनरली काय असतं की लोअर लिमचं ब्लड प्रेशर अप्पर लिमच्या ब्लड प्रेशरपेक्षा जास्ती असतं. ठीक आहे, थोडंसं जास्त असतं लोअर लिमचं ब्लड प्रेशर. पण लोअर लिमचं ब्लड प्रेशर जर कमी आलं किंवा रेशो जर 1पेक्षा कमी आला, 0.9 पेक्षा कमी आला, तर इट इज वेअर यू सस्पेक्ट द पेरिफेरल आर्टेरियल डिसीज. मग पुढचं टेस्ट काय करायचं आहे? किंवा अल्ट्रासाऊंड, ट्युप्लेक्स अल्ट्रासाऊंड. नेक्स्ट जे आपण कॉमन कलर डॉपलर करून लिहून देतो, कलर डॉपलर राईट लोअर लिम, कलर डॉपलर लेफ्ट लोअर लिम. त्याच्यामध्ये काय बघतात? ड्युप्लेक्स म्हणजे काय की बी मोड आणि डॉपलर हे दोन एकत्र वापरून ड्युप्लेक्स अल्ट्रासोनोग्राफी करतात. त्याच्यामध्ये ते काय बघतात की वेसल्स कुठं आहेत आणि कुठे काय ब्लॉकेजेस आहेत का. जर त्याच्यात सिग्निफिकंट नेक्स्ट घेत राहा, ज्याच्यामध्ये जर सिग्निफिकंट ब्लॉकेजेस असतील तर नेक्स्ट इन्व्हेस्टिगेशन काय? सिटी एनजीओ किंवा एम आर एनजीओ. तर क्रिएटिन नॉर्मल असेल तर सिटी एनजीओला जायचं. क्रिएट नॉर्मल नसेल, काही रिनल इश्यू असेल तर एम आर एनजीओ. एम आर एनजीओ इज सेफ. ठीक आहे. त्यात जर तुम्हाला क्रिटिकल ब्लॉकेज असेल, क्रिटिकल ब्लॉकेज म्हणजे काय की कुठेही आपल्याला 70% इज द कट ऑफ. इव्हन कॉर्नरीजमध्ये असेल तर 70% कट ऑफ असतो. 70%च्या खाली ब्लॉक असेल तर आपण मेडिकल मॅनेजमेंट करायचे. 70%च्या वर ब्लॉक असेल तर आपण त्याला सर्जिकल मॅनेजमेंट करायला पाहिजे. तर सर्जिकल मॅनेजमेंटमध्ये काय असतं? एक तर सेम, एक तर एंडोव्हॅस्क्युलर किंवा ओपन सर्जिकल. तर एंडोव्हॅस्क्युलर म्हणजे काय की जसं आपण पीटीए करतो, परक्युटेनियस ट्रान्सल्युमिनल अँजिओप्लास्टी, काय करतो? वायर पास करतो, बलून असतो, बलूननी इन्फ्लेट करतो आणि तिथं स्टेंट ठेवून टाकतो. तसं करोनरीला करतात, सेम तसं आपल्याला पेरिफेरलला करता येतं. एक तर अँजिओप्लास्टी किंवा मग बायपास ग्राफ्टिंग. बायपास ग्राफ्टिंगला काय करायचं? जसं हार्टचा बायपास करतो तसं सॅपेनस व्हेन काढायची, ब्लॉकेज कुठं आहे बघायचं, त्याचा प्रॉक्सिमली आणि डिस्टली कनेक्ट करून टाकायचं आणि जो ब्लॉक आहे त्याला आपण बायपास करून टाकायचं. आता ह्याचे इश्यू काय आहेत की सेम जसं करोनरीसाठी अँजिओप्लास्टी झाली की अँटीप्लेटेड कंपल्सरी घ्यावे लागतात, तसं इकडे अँटीप्लेटेड कंपल्सरी घ्यावे लागतात. कारण की स्टेंट ब्लॉक होण्याची शक्यता नॉर्मल आर्टरीपेक्षा जास्त असते, कारण की स्टेंट हे शेवटी फॉरेन मटेरियल आहे. त्यामुळं अथेरोस्क्लेरोसिस, थ्रोम्बोसिस, कोलेस्ट्रॉल डिपॉझिट होणं हे स्टेंटमध्ये फास्ट होतं. त्यामुळे आपण कार्डियाक पेशंटमध्ये सुद्धा प्लास्टी झाली की कंपल्सरी अँटीप्लेट जास्त घ्यावं लागतात. बायपासच्या वेळेस काय करतो? अँटीप्लेट आपण कमी ठेवतो. प्लास्टीला उलटं स्टेंट ब्लॉक होण्याचे चान्सेस जास्त असल्यामुळे अँटीप्लेटलेट्स जास्त स्ट्रॉंग ठेवावं लागतात. सेम इथं पण आहे. नेक्स्ट तर सिटी एनजीओ, एम आर एनजीओ ह्याच्यामध्ये जर 70% ब्लॉक असेल तर ते कन्फर्मेशन एकदम द डायग्नॉस्टिक टेस्ट किंवा गोल्ड स्टँडर्ड टेस्ट काय की इन्व्हेजिव्ह एनजीओ. जर तुम्ही काही इंटरव्हेन्शन करणार असेल तरच मग इन्व्हेजिव्ह एनजीओ इज द गोल्ड स्टँडर्ड टेस्ट. मग इन्व्हेजिव्ह एनजीओ जसं आपण कार्डिओलॉजिस्ट करोनरी एनजीओ करतात, सेम कॅथेटर पास करायचं, डायट इंजेक्ट करायची आणि एक्झॅक्टली कुठं ब्लॉकेज आहे ते बघायचं. आणि डिपेंडिंग अपॉन द लेवल ऑफ ब्लॉकेज अँजिओप्लास्टी किंवा बायपासचा पर्याय असतो. आता याच्यामध्ये डिसीज कुठं आहे? आता स्टार्ट फ्रॉम ॲओर्टा, त्याच्या 2 ब्रँचेस आला आयलियाक आर्टरी, त्याच्यानंतर आलं फिमोरल, त्याच्यानंतर आलं पॉप्लिटियल. तर जसं जसं डिसीज खाली खाली जातो तसं तसं चान्सेस कमी होतात सक्सेसफुल होण्याचे. प्लास्टिक वरच्या वेसलमध्ये केली, ॲओर्टा आयलियाकमध्ये किंवा आयलियाक आर्टरीजमध्ये केले तर त्याचे रिझल्ट चांगले असतात. पेरिफेरलला केले त्याचे रिझल्ट कमी असतात, कारण की लुमेन पण आर्टरीचा नॅरो नॅरो होत जातो आणि त्याचे डिसीज पण डिफ्यूज होत जातो. आता मॅनेजमेंटसाठी काय स्ट्रॅटेजी आहेत? एक तर शुगर कंट्रोल. ज्याला डायबिटीज आहे स्ट्रिक्टली शुगर कंट्रोल पाहिजे, HbA1c 7च्या खाली पाहिजे, फास्टिंग 100, PP 150, स्ट्रिक्टली ग्लायसेमिक कंट्रोल पाहिजे, तर तुमचा अथेरोस्क्लेरोसिस स्लो होणार आहे. दुसरी गोष्ट BP. ॲक्च्युली आपण टार्गेट काय करतो 130-80 आणि जरा थोडं हायर साईड सांगितलं, पण आपण डायबिटीज, हायपरटेन्शन फॉर एनी डिसीज आपलं टार्गेट असलं पाहिजे 130-80. कुठले ड्रग्ज वापरणार? ACE इनहिबिटर, ARB फर्स्ट क्लास. पण युजली टेल्मिसार्टन, ओल्मिसार्टन हे जे ARBs आहेत ते युजली प्रेफर करतो. ओनली थिंग की क्रियाट जास्त नसायला पाहिजे, पोटॅशियम नॉर्मल असायला पाहिजे. हे दोनच गोष्टी टेल्मिसार्टन देताना काळजी केला पाहिजे. आता बराच क्वेश्चन असतो की बीटा ब्लॉकर पेरिफेरल आर्टरी डिसीजमध्ये वापरायचे का नाही वापरायचे. तर त्याच्या गाईडलाईन्स काय आहेत की बाबा क्रिटिकल लिम्ब इश्चिमिया असेल तर बीटा ब्लॉकर्स आर कॉन्ट्रा इंडिकेटेड. अदरवाईज रुटीन पेरिफेरल आर्टरी डिसीज पेशंट्सला बीटा ब्लॉकर द्यायला काही प्रॉब्लेम नाही. का? कारण की पेरिफेरल आर्टरी डिसीज आणि करोनरी आर्टरी डिसीज हँड इन हँड जातात. जसं किडनी फेल आणि रेटॅनोपॅथी हे सोबत जातात, तसं बेसिकली हे अथेरोस्क्लेरोसिस आहे. त्यामुळे सगळ्याच स्पेशलमध्ये होणार आहेत. जनरली जे पेरिफेरल आर्टरी डिसीजमध्ये लोकांना अथेरोस्क्लेरोसिस होतं त्याच्या ऑलमोस्ट 50% लोकांमध्ये करोनरीमध्ये पण ब्लॉकेज असतं. जेव्हा पेरिफेरल आर्टरी डिसीज डायग्नोज होतं त्यावेळी त्या पेशंटला करोनरी आहे का नाही हे पण सेम बघणं गरजेचं आहे. जेव्हा तुम्हाला एखादा पेशंट येईल पेरिफेरल आर्टरी डिसीज, त्याचा ECG काढून, त्याचा इको बघून, कार्डियक पण काही सिम्पटम्स आहेत का, बाबा चालल्यानंतर अंजायना आहे, चालल्यानंतर डिस्निया आहे, ते पण गोष्टी बघायला पाहिजेत. आता त्यांनी LDL कोलेस्ट्रॉलबद्दल म्हणले. आता LDL कोलेस्ट्रॉलचे काय गाईडलाईन्स आहेत की जनरल पेशंट ज्याच्यामध्ये काही रिस्क फॅक्टर नाही, त्याच्यामध्ये कट ऑफ काय आहे 100च्या खाली पाहिजे, काहीच त्याला रिस्क फॅक्टर नाही आहे, त्या पेशंटमध्ये LDL कोलेस्ट्रॉल पण 100च्या आत पाहिजे. 100च्या आत पाहिजे, मग त्यासाठी काय करायला पाहिजे? स्ट्रिक्टली डाएट, एक्सरसाइज, वेट रिडक्शन, ही आपली लाईफस्टाईल मॉडिफिकेशन. त्यानंतर काय की स्टॅटिन्स आहेत. स्टॅटिन्समध्ये काय की ॲट्रोस्टॅटिन, रोझोस्टॅटिन. हाय इंटेन्सिटी स्टॅटिन्स म्हणजे ॲट्रोस्टॅटिन 40 मिलीग्राम. इक्विव्हॅलंट डोस रोझोस्टॅटिनचा हाफ डोस असतो. रोझोस्टॅटिन 20 मिलीग्राम. पहिले स्टॅटिन वापरून बघायचं आहे. स्टॅटिन रिझल्ट येत नाही तर सेकंड ड्रग इझेटिमॅब ॲड करायचं आहे. सेकंड ड्रग आहे की इझेटिमॅब ॲड करायचं आहे LDL हाय करून कंट्रोल करायसाठी. स्टॅटिन देताना काळजी काय घ्यायची आहेत? ओन्ली 2 थिंग्स. एक तर म्हणजे एन्झाईम्स, लिव्हर एन्झाईम्स, SGOT, PT बघायचं, ते वाढत नाही ना लक्षात घ्यायचं. अँड सेकंड थिंग इज मायोपॅथी. कधी कधी स्टॅटिन इंड्यूस मायोपॅथी होते. स्टॅटिन चालू केल्यानंतर कोणाला क्रॅम्प्स येत असतील तर CPK टोटल इज द डायग्नॉस्टिक टेस्ट. CPK टोटल करायचं. CPK टोटल खूप जास्त वाढला असेल तर ते स्टॅटिनमुळे वाढलं, इमिजिएटली स्टॅटिन बंद करायचं. तर LDL कोलेस्ट्रॉल नॉर्मल पेशंट्समध्ये 100च्या खाली पाहिजे. ज्याला अथेरोस्क्लेरोटिक कार्डिओव्हास्क्युलर डिसीजचा एखादा एपिसोड झाला आहे त्याच्यामध्ये टार्गेट शुड बी 70. आणि ज्याला मल्टिपल एपिसोड झाले आहेत त्याच्यामध्ये बिलो 50 किंवा ऑलमोस्ट ज्याला खूपच हार्ट अटॅक पण झाला आहे, स्ट्रोक पण झाला आहे, पेरिफेरल आर्टरी डिसीज पण आहेत, मल्टिपल आजार आहेत, त्याच्यामध्ये अगदी LDL बिलो 50, बिलो 30 कमी करा असे गाईडलाईन्स आहेत. दुसरी गोष्ट आपण कधीच करत नाही ती टेस्ट म्हणजे लायप्रोटीन A. बऱ्याच वेळा लिपिड नॉर्मल असते पण लायप्रोटीन A पण करायला पाहिजे. लायप्रोटीन A जर वाढलेला असेल दॅट इज ऑल्सो सिग्निफिकंट रिस्क फॅक्टर फॉर डेव्हलपमेंट ऑफ कार्डियक डिसीजेस. दुसरी गोष्ट आयडियल बॉडी वेट, बॉडी मास इंडेक्स नॉर्मल असणं हे गरजेचं आहे. ॲबडॉमिनल ओबेसिटी हा फार मोठा रिस्क फॅक्टर आहे कुठेही अथेरोस्क्लेरोसिस होण्यासाठी. त्यासाठी ॲबडॉमिनल ओबेसिटी कंट्रोलमध्ये पाहिजे. आयडियल बॉडी वेट मेंटेन करायला पाहिजे. आता अँटीप्लेटलेट्समध्ये त्यांनी काय म्हणलंय की ॲस्पिरिन सगळ्यात सेफ रुटीनली वापरणारं अँटीप्लेटलेट. जेव्हा रिस्क जास्त असते, पेरिफेरल आर्टरी डिसीज सिग्निफिकंट असतो, त्यावेळी डबल अँटीप्लेट वापरायचे. ॲस्पिरिन प्लस क्लोपिडोग्रेल, त्याला DAPT म्हणतो, डबल अँटीप्लेट. किंवा नवीन स्ट्रॅटेजी काय आले की बाबा डबल अँटीप्लेटलेट प्लस सिंगल अँटीप्लेट ॲस्पिरिन प्लस रिओरॉक्साबॅन. रिओरॉक्साबॅन काय आहे? अँटीथ्रॉम्बॉटिक आहे. आपण कशासाठी वापरतो? डीप वेन थ्रॉम्बॉसिसमध्ये वापरतो, पल्मोनरी एम्बोलिझममध्ये वापरतो. पण त्याचा डोस काय असतो? ट्रीटमेंटसाठी डीप वेन थ्रॉम्बोसिस किंवा पल्मोनरी एम्बोलिझमच्या ट्रीटमेंटसाठी रिओरॉक्साबॅन आपण 20 मिलीग्राम वन्स अ डे देतो, 20 मिलीग्राम. DVT प्रिव्हेन्शन करायचं असेल ना, काहीतरी जॉईंट हिप रिप्लेसमेंट झालं तर आपण प्रोफायलॅक्सिस म्हणून देतो की ह्या माणसाला DVT होऊ नये. त्यासाठी किती देतो? 10 मिलीग्राम वन्स अ डे. याच्यासाठी पेरिफेरल आर्टरी डिसीजसाठी डोस त्यांनी गाईडलाईन्समध्ये असं शोधून काढलं की 2.5 मिलीग्राम ट्वाईस अ डे. ॲस्पिरिन 75 प्लस रिव्हरॉक्साबॅन 2.5 मिलीग्राम ट्वाईस अ डे. दिस आर द अँटीप्लेटलेट्स. आयदर तुम्ही दोन्हीतलं एक काहीतरी वापरू शकता. एकतर ॲस्पिरिन अलॉंग विथ टिकाग्रेलॉर किंवा ॲस्पिरिन प्लस क्लोपिडोग्रेल किंवा ॲस्पिरिन प्लस रिव्हरॉक्साबॅन. ह्या तिन्हीतलं काहीतरी वापरायचं आहे. इट इज मस्ट फॉर ऑल PAD पेशंट्स. ठीक आहे, ॲटलिस्ट पहिले इनिशियली 6 मंथसाठी तरी. दुसरी गोष्ट आपलं हे जे ड्रग आहे सिलोस्टाझोल हे काय आहे फॉस्फोडायस्ट्रेस 3 इनिबिटर आहे. बेसिकली इट इज अ फॉस्फोडायस्ट्रेस 3 इनिबिटर्स. फॉस्फोडायस्ट्रेस 3 कुठं असतं जास्त पेरिफरल आर्टरीजमध्ये. त्यामुळे ते पेरिफरल आर्टरीसाठी चांगलं काम करते. कार्डियकसाठी ते वापरत नाहीत. मेनली पेरिफरल आर्टरीजसाठी वापरतात. त्याचे मेन प्रॉपर्टीज काय आहेत एक अँटीप्लेटलेट इफेक्ट आहे आणि वेसोडायलेटर आहेत. त्यामुळे थोडं वेसोडायलेटेशन होते. आता हे अँटीप्लेटलेटच आहे त्यामुळं महत्त्वाचं काय की स्टॉप कधी करायचं. मायनर सर्जरी असेल तर 24 अवर्स प्रायर टू सर्जरी बंद करायचं. मेजर सर्जरी असेल तर ॲटलिस्ट 48 अवर्स आधी बंद करायचं. ठीक आहे. पेंटॉक्सिफॅलिन ट्रेंटाल पूर्वी वापरायचे. आता सगळ्या गाईडलाईन्समध्ये त्याचा काय रोल नाही आहे पेंटॉक्सिफॅलिनचा. तर 15 नेक्स्ट मोस्ट काय की बाबा पाल्पेटिंग अ पेरिफरल आर्टरी शुड बी हॅबिट इन रेग्युलर प्रॅक्टिस फॉर ऑल हेल्थ केअर प्रोफेशनल्स. ठीक आहे. ड्रॉसली स्पीडीज पाल्पेट करणं पोस्टेटिबल आर्टरी पाल्पेट करणं शुड बी रेग्युलर हॅबिट. फूड हायजीन आणि फूड केअर शिकवणं तेही तितकंच गरजेचं आहे. ठीक आहे. नेक्स्ट. आणि जेव्हा आपण सर्जरी जेव्हा पण आपण सर्जरी ॲडवाईज करतो तेव्हा फर्स्ट प्रायोरिटी असली पाहिजे की लिंब सेव्ह करणं. तुम्ही बरेचसे तुमच्याकडे पेशंट्स रेफर होतात किंवा ऐकत असतात त्याच्यामध्ये काय की 2-3 ऑप्शन असतात. तुम्ही बऱ्याच वेळा सर्जन ॲडवाईज करतात की बाबा डिब्रायडमेंट करू शकतो किंवा ब्लॉकेज जास्त आहेत, पेरिफरल आर्टरी डिसीज आहेत, असेल स्पीडीज पाल्पेट होत नाही, पोस्टेटिबल पाल्पेट होत नाही, डॉप्लरला पण नाही आहे, सरळ ॲम्प्यूट करूया. ॲम्प्यूट करायला प्रॉब्लेम काय असतो की एकतर म्हणजे आर्टिफिशियल लिंब नंतर लावणं ते टेक्निकली फार डिफिकल्ट असतं आणि आर्टिफिशियल लिंब घेऊन चालणं आणि नॅचरली पाय घेऊन चालणं याच्यात जमीन अस्मानचा फरक आहे. कितीही चांगलं कुठनंही इकडचा तिकडचं कुठनंही ऑल ओव्हर इंडिया कुठनंही फूट आणला तरी शेवटी आर्टिफिशियल आहे. त्यामुळे प्रायोरिटी कशाला असली पाहिजे की चांगलं प्रॉपर डिब्रायडमेंट आणि डिब्रायडमेंट होऊन पण जर शक्यच नाही होत आहे चांगले अँटीप्लेटलेट्स चांगले सिलोस्टॉझोल वगैरे सगळं ड्रग वापरून तर ते फेल होते तर लास्ट ऑप्शन इज ॲम्प्युटेशन. सो ॲम्प्युटेशन शुड बी ऑलवेज बी अ लास्ट ऑप्शन. लिंब सेव्हिंग पाय वाचवणं दॅट शुड बी अवर प्रायोरिटी इन एनी ऑल केसेस. अनलेस अँड अंटिल एकदम क्रिटिकल लिंब इश्यूमी आहे गँग्रीन झालंय त्यावेळेस मग ठीक आहे. गँग्रीनला आहे क्रिएटिन वाढले ल्युकोसायटॉसिस खूप जास्त आहे सेप्सिसमध्ये चाललंय सेप्टिकमध्ये शॉकमध्ये चाललंय डायलिसिस लागायला लागले अशा वेळेस मग बेटर वे लाईफ सेव्हिंग स्ट्रेट वे गो फॉर ॲम्प्युटेशन. एक छोटी केस आहे ती बघूया आपण. नेक्स्ट. 65 ओल्ड मेल डायबिटीज आहे हायपरटेन्शन आहे प्रेझेंटेड विथ क्रोनिक लोअर लिम्ब पेन इट इज वर्सनिंग फॉर लास्ट 6 months. BP 190 100 HbA1c 8 LDL 170 HDL 35 मेटफॉर्मिन आणि सिताग्लिप्टिन आणि डाएट कंट्रोलवरती आहे. सिम्पटम्स काय आहेत की काफमध्ये पेन होते. आता हे टिपिकली ऑफ क्लॉडिकेशन. व्हॉट डू बाय क्लॉडिकेशन? दॅट काफ पेन इज इन्क्रीज बाय वॉकिंग. पेशंट सांगतो तुम्हाला की मला एक 100 फूट चालल्यानंतर नेहमी असं पाय दुखायला लागतात थांबायला लागतो थांबलो रेस्ट घेतो दुखणं कमी येते परत चालायला लागतो परत 100 फूट चालतो परत थांबतो. इज अ टिपिकल हिस्ट्री ऑफ इंटरमिटेंट क्लॉडिकेशन. एक ठराविक डिस्टन्स गेल्यानंतर थांबावं लागतंय रेस्ट घेतो पेन पूर्ण बंद होते परत चालायला लागतो. तर बाकी नमनेस टिंगलिंग विकनेस हे सगळे सिम्पटम्स. आता ह्याच्यामध्ये ॲबनॉर्मल काय याच्यात आणि काय द्यायला पाहिजे त्यांनी की वेट एक द्यायला पाहिजे होतं कारण की आयडियल बॉडी वेट मेंटेन करणं गरजेचं आहे आणि हॅबिट्स त्याचे सांगणं महत्त्वाचं होतं. पेशंटला स्मोकिंग आहे काय त्याच्यात ॲबनॉर्मल काय काय एजला तर आपण काय करू शकत नाही. 65 आहे अथेरोस्क्लेरोसिस होणारच आहे. एज काय रिव्हर्स करू शकत नाही. डायबिटीज स्ट्रिक्टली कंट्रोल असणं गरजेचं आहे. HbA1c 8 आहे. HbA1c कंपल्सरी 7 आलंच पाहिजे. जितकं टाईट शुगर कंट्रोल आहे तितक्या सगळ्या गोष्टी थांबणार आहेत. हायपरटेन्शन 190 BP आहे. अजिबात कंट्रोल नाही आहे. तुम्हाला त्यांच्या अँटीहायपरटेन्शन काय आहेत बघायला पाहिजेत रिवाईज करायला पाहिजेत आहे तो डोस वाढवायला पाहिजे किंवा सेकंड अँटीहायपरटेन्सिव्ह ॲड करायला पाहिजे थर्ड अँटीहायपरटेन्सिव्ह ॲड करायला पाहिजे डिपेंडिंग आपण काय त्याची चालू आहे मेडिसिन ते बघायला पाहिजे. LDL आपण काय म्हणलं ॲटलिस्ट 70 ते टार्गेट ठेवायला पाहिजे. 100 नॉर्मल पेशंटमध्ये पण ह्याला ऑलरेडी पेरिफरल आर्टरी डिसीज आहे तर आपण 70 टार्गेट ठेवायला पाहिजे. HDL पण खूप लो आहे पण HDL वाढवायसाठी काही औषध नाही आहे. HDLसाठी इकडंच वेट रिडक्शन आणि एक्सरसाइज एवढं एकच त्याला काय मेडिसिन नाही HDL वाढवायचं. HDL इज गुड कोलेस्ट्रॉल ॲटलिस्ट 40च्या अबोव पाहिजे मेल्समध्ये फिमेल्समध्ये 60च्या अबोव पाहिजे. आता मेटफॉर्मिन आणि सिताग्लिप्टिन आहे त्याचं ऑब्व्हियसली आपल्याला वाढवायला पाहिजे. एखादं डोस किती चालला आहे मेटफॉर्मिन 500 असेल तर आपण ते 1500 2 ग्रॅमपर्यंत जाऊ शकतो. सिताग्लिप्टिन 50चा असेल तर 100पर्यंत जाऊ शकतो. डाएट स्ट्रिक्टली फॉलो करतोय की नाही करतोय त्यानुसार डाएट ॲडवाईस करू शकतो. ग्लिमेपिरियड एखादा ॲड करू शकतो डिपेंडिंग अपॉन फास्टिंग BP. नेक्स्ट. आता पेशंट प्रेझेंटेड विथ काफ वेन स्क्रीन कसं करणार? पहिली गोष्ट डॉर्सलिस पीडीस पाल्पेट करणार, पोस्टेरियल पाल्पेट करणार, बरोबर आहे. ते जर ॲबसेंट असेल, वीक लागत असेल, फिबल लागत असेल तर नेक्स्ट थिंग इज सिम्पल गोष्ट अँकल ब्रेकेल इंडेक्स करणार. लोअर लिममध्ये काफला बीपी कप गुंडाळून तिथं सिस्टॉलिक बीपी बघायचं, वरचं अप्पर लिमचं बीपी बघायचं, त्याचा रेशो काढायचा. 0.9% पेक्षा खाली असेल तर डेफिनेटली त्याला पेरिफेरल आर्टरी डिसीज आहे. व्हॉट विल यू डू नेक्स्ट? कलर डॉपलर, डुप्लेक्स अल्ट्रासाउंड, कलर डॉपलर ॲडवाइस करणे. ठीक. आता ही दोन गोष्टी आहे, वॅस्क्युलोजेनिक आहे की न्यूरोजेनिक आहे. वॅस्क्युलोजेनिक म्हणजे काय की पेरिफेरल आर्टेरियल डिसीज, दिस इज प्रॉब्लेम ऑफ वेसल, रिड्यूस ब्लड सप्लाय टू द लोअर लिम्स, म्हणजे वॅस्क्युलोजेनिक. न्यूरोजेनिक म्हणजे काय? नाही, न्यूरोजेनिक म्हणजे काय की लंबार कॅनल जो आहे, जिथनं आपले स्पायनल कॉर्ड जाते आणि जिथनं पेरिफेरल नर्व्स जातात, तर तिथं काहीतरी प्रॉब्लेम आहे. मग डिस्क असेल, लंबार कॅनल स्टिनोसिस असेल, वॉट एव्हर. आता हिस्ट्री डिफरन्शिएट कर, दोन्ही पेशंट काय म्हणणार आहे की काफमध्ये पेन आहे. फरक काय असणार आहे की जे वॅस्क्युलोजेनिक क्लॉडिकेशन आहे ते टिपिकल हिस्ट्री काय असणार आहे की एवढं अंतर जातोय, थांबतोय, थांबल्यानंतर बरं वाटतंय. न्यूरोजेनिकमध्ये काय असतं की पोस्चर रिलेटेड असते. काही हेवी वजन उचललं असेल तर त्यानंतर ते पेन वाढतं. असं लिनिंग फॉरवर्ड फ्लेक्शन केल्यानंतर पेन कमी होतं. पेशंट वाकून वाकून चालतात असे पेशंट. वाकल्यानंतर त्यांना बरं वाटतं. वाकल्यानंतर बरं वाटतं म्हणजे दॅट इज न्यूरोजेनिक क्लॉडिकेशन. दॅट इज मोस्ट इम्पॉर्टंट क्लू. इन्व्हेस्टिगेट कसं करणार आहे? वॅस्क्युलोजेनिक आहे, तुम्हाला पल्स बघून समजणार आहे, पल्स बघून समजणार आहे, डॉपलर करून समजणार आहे. न्यूरोजेनिक कसं ओळखणार आहे? MRI करायला पाहिजे. MRI लंबोसॅक्रल स्पाइन विथ होल स्पाइन स्क्रीनिंग तुम्हाला कन्फर्म डायग्नोसिस करणार आहे किंवा आहे की नाही आहे. ठीक आहे. नेक्स्ट, कुठलाही डिसीज असला, काही आजार असला की फर्स्ट काय? लाईफस्टाईल मॉडिफिकेशन. स्मोकिंग आहे का? असेल तर बंद, कम्प्लीट स्टॉप. स्मोकिंग बंद करायसाठी काय? एकतर चांगलं काउन्सिलिंग, किंवा हे सगळं होतंय ते स्मोकिंगमुळेच होतंय, आत्ता प्यायात झालाय, उद्या अटॅक येणार आहे, बरोबर आहे. दुसरी गोष्ट, त्याला निकोटीन गम्स, निकोटीन पॅच किंवा बिप्रोपियॉन टॅबलेट वापरू शकतो त्याचं ॲडिक्शन कमी करायसाठी. अगदीच वर्स्ट सिनारिओमध्ये सायकॅट्रिक रेफरन्स पण देऊ शकतो. तर स्मोकिंग पहिलं बंद करायला पाहिजे. सेकंड थिंग, एक्सरसाइज. आता ज्याला क्लॉडिकेशन आहे त्यांना एक्सरसाइज करावं की न करावं, तर त्याला एक चांगल्या फिजिओथेरपिस्टला भेटून एक्सरसाइज ट्रेनिंग द्यायला हवं. असं नाही आहे की क्लॉडिकेशन होते म्हणून त्यांना एक्सरसाइज करू नये. त्याचं एक्सरसाइज डिस्टन्स किंवा क्लॉडिकेशन डिस्टन्स हळूहळू जर चांगली एक्सरसाइज केली तर ते डिस्टन्स पण वाढू शकतो. तुम्हाला प्रॉपर पहिलं मेडिसिन स्टार्ट करा, ॲस्पिरिन चालू करा, सिलोस्टेरॉल चालू करा, स्टॅटिन चालू करा, रिस्क फॅक्टर मॉडिफाय करा आणि त्याला ग्रॅज्युअली, आज इतकं डिस्टन्स चालतोय, थांबतोय, ठीक आहे, परत चालतोय, आज एक 10 मिनिटं, 2 दिवसांनी एक परत 15 मिनिटं, 2 दिवसांना परत 20 मिनिटं, 2 दिवसांना परत 30 मिनिटं, 2 दिवसांना परत 40 मिनिटं. गो स्टेप बाय स्टेप. 8 दिवस लागू दे, 15 दिवस लागू दे, पण त्याला एक्सरसाइज करायला पाहिजे. एक्सरसाइज न करणं हा कायचा उपाय नाही, किंवा दुखते म्हणून थांबणं हा काय उपाय नाही आहे. डायटरी मॉडिफिकेशन्स, हेल्दी लाईफस्टाईल, लो इन फॅट्स, कोलेस्ट्रॉल, सोडियम, सॉल्ट रिस्ट्रिक्शन, जे रेग्युलर आपण कार्डियक पेशंटसाठी सांगतो ते सगळं. वेट मॅनेजमेंट, वजन जास्त असेल तर वजन कमी करणं. अगेन वेट लॉससाठी काय? अगेन डाएट, एक्सरसाइज, कार्बोहायड्रेट्स कमी करणं, स्वीट सगळं बंद करणं, प्रोटीन इंटेक वाढवणं. इन्व्हेस्टिगेट काय करणार? ब्लड काउंट, HB किती आहे, काउंट किती आहे. काउंट कशासाठी? किंवा इन्फेक्शन झालं आहे का तिथं. कधी कधी गुंड असतात. डायबेटिक पेशंटमध्ये न्यूरोपॅथीसुद्धा सोबत असते. न्यूरोपॅथीमध्ये पेन होत नाही, साध्या साध्या जखमा झालेल्या कळत नाहीत, त्यामुळं इन्फेक्शन झालं आहे का, कधी कधी वरून फार अंदाज येत नाही, आतमध्ये जखम डीप असते, तर काउंट समजणार आहे, फीवरची हिस्ट्री असणार आहे, वॉर्म लागणार आहे. कोलेस्ट्रॉल, मेनली त्यात LDL किती आहे, HbA1c 7च्या आत खाली आहे का नाही आहे, फास्टिंग PP, HSCRP. HSCRP एक फार महत्त्वाचा, नुसतं CRP नाही आहे, हे HSCRP आहे, हाय सेन्सिटिव्हिटी CRP. हे एक फार मोठं रिस्क फॅक्टर आहे अथरोस्क्लेरोसिससाठी. HSCRP जर मोर दॅन 2 असेल, दॅट इज अ हाय रिस्क फॅक्टर टू डेव्हलप प्रीमॅच्युअर अथरोस्क्लेरोटिक डिसीज. मग कार्डियक असेल, पेरिफेरल असेल. HSCRP आणि लायप्रोटीन A, ह्या दोन गोष्टी लक्षात ठेवा. ह्या दोन गोष्टी आपण रुटीनली करायला पाहिजे. HSCRP आणि लायप्रोटीन A. जेव्हा आपण जनरल चेकअप करतो एखाद्या माणसाचं, किंवा त्याला फ्युचरमध्ये रिस्क किती आहे. एक्सरे फार डायग्नॉस्टिक नसतं ह्याच्यामध्ये. तुम्हाला करायचं डायरेक्टली स्ट्रेट अवे MRI स्कॅन करायला. एक्सरेला काय करणार आहे, तुम्हाला ग्रॉसली कुठं फ्रॅक्चर आहे का तेवढंच समजणार. बाकी कॅनाल बघायसाठी किंवा तुमच्या नर्व रूट कॉम्प्रेशनसाठी MRI इज द बेस्ट ऑप्शन. जसं मी म्हटलं की कोरोनरी आर्टरी डिसीज आणि पेरिफेरल डिसीज गो हँड्स इन हँड. त्यामुळं ECG आणि ज्याला अंजाना आहे, डिस्नी आहे, त्याचा इको हे पण करणं गरजेचं आहे. अँटीप्लेटलेट्स ॲस्पिरिन प्लस मायनस क्लोपिडोग्रेल. ज्याला हाय रिस्क आहे त्याला ॲस्पिरिन प्लस मायनस युरॉक्साबॅन. तर युरॉक्साबॅनचं रिस्क काय आहे की ब्लिडिंगची रिस्क जास्त असते क्लोपिडोग्रेलपेक्षा. मग एखाद्या पेशंटला ब्लिडिंगची रिस्क ऑलरेडी जर जास्त असेल, एज खूप जास्त आहे, पेशंट सांगतात आपल्याला कधी कधी इकॅमोसिस डेव्हलप होत असते, छोटं छोटं कुठं लागलं, एल्डरली लोकांना स्पेसिफिकली आता कुठं थडकलं तिथे लगेच इकॅमोसिस होतं. अशा पेशंटमध्ये फार जपून अँटीप्लेट द्यायला पाहिजे. सिंगल अँटीप्लेट आणि लो डोस 75, 150 कधीही द्यायचं नाही. स्टॅटिन, हायड्रोस्टॅटिन्स. स्टॅटिन्समध्ये दोनच गोष्टी, एसजीओटी पीटी वाढतंय का बघायचं आणि मायोपॅथी होते का. सिलोस्टेझल सगळ्यांना देऊ शकतोय, नो इश्यू. फक्त त्यांनी जसं सांगितलं की कार्डियक फेलियर, हार्ट फेलियर असेल, कंजेस्टिव्ह हार्ट फेलियर असेल तर सिलोस्टेझल इज कॉन्ट्राइंडिकेटेड. डोस काय 100 मिलीग्राम ट्वाईस अ डे. बरेच लोक 50 mg देतात, त्यांना काही फायदा होत नाही. 100 मिलीग्राम ट्वाईस अ डे. आणि इट इज ओनली ड्रग दॅट हॅज बीन प्रूव्ह टू इन्क्रीज द क्लॉडिकेशन डिस्टन्स. हे स्टार्ट केल्यानंतर क्लॉडिकेशन डिस्टन्स वाढतं. आणि कधी वाढतं, आज चालू केली सिलोस्टेझल म्हणजे उद्या लगेच क्लॉडिकेशन डिस्टन्स वाढणार नाही आहे. तुम्हाला पेशंटला तर सांगताना सांगायला पाहिजे की ॲटलिस्ट 1 to 3 months लागणार आहेत त्याच्या ॲक्शन यायला, वेसोडायलेटेशन व्हायला आणि तुमचं क्लॉडिकेशन डिस्टन्स वाढायला. आज सिलोस्टेझल चालू केले की उद्या लगेच डिस्टन्स वाढणार आणि तुमचं पाय बरा होणार असं होणार नाही आहे. सेकंड थिंग पेन. आता सिम्टमॅटिक रिलीफ तर द्यायलाच पाहिजे. क्रियाट नॉर्मल असेल तर NSAIDs, नसेल तर पॅरासिटामॉल, ट्रामोडॉल, हे ऑप्शन्स आहेत. सेकंड, डायबिटीज, HbA1c बिलो 7, हायपरटेन्शन 130/80 टार्गेट, सॉल्ट रिस्ट्रिक्शन आणि अँटीहायपरटेन्सिव्ह वाईजली यूज करायचे. बीटा ब्लॉकर जसं सांगितलं, कॉरोनरी डिसीज असेल तर कंपल्सरी बीटा ब्लॉकर द्यायलाच पाहिजेत. कॉरोनरी डिसीज नसेल तर आपण बीटा ब्लॉकरसाठी वेट करू शकतो. ओनली थिंग इज क्रिटिकल लिम्ब इश्यू असेल तर बीटा ब्लॉकर स्ट्रिक्टली कॉन्ट्राइंडिकेटेड. म्हणजे अगदी त्याला ॲडमिट केलं आहे अशा सिच्युएशन्समध्ये स्ट्रिक्टली कॉन्ट्राइंडिकेटेड. ठीक. नेक्स्ट guidelines. So it is final statement. In patients with claudication, silostazol is recommended to improve the leg symptoms and increase the walking distance. In patients with peripheral arterial disease, silostazol may be useful to reduce the restenosis after endovascular therapy for the femoropopliteal disease. Heart failure, congestive heart failure, any severity, silostazol not recommended. So thank you very much. I also thank Team Integrace for giving me this opportunity. काही डाऊट्स असतील तर आपण डिस्कस करू शकतो.
Questions, anyone?
So thank you everyone.
Thank you so much. Sir, just एक Hello. Yes, sir, we would like to invite you once more. Just a small token of our appreciation for this session. Thank you so much, sir. Thank you, sir. Lunch. It's served outside, right? बाहेर इथेच आहे. Move there. Thank you, everyone. Thank you. टच वेगळा असतो ना तो वेगळा. सिंपल मध्ये तासा